There definitely is not a dearth of evidence. There's just a dearth of high quality evidence supporting the 180 beats per minute. There was a study that was done in 2020 where they looked at 381 soldiers, and they actually did not find a relationship between step rate and injury risk. This is the largest population, to my knowledge. I'm sure there's probably bigger ones going on now that kind of looks at that, specifically at Army soldiers. But I think that's probably the most like powerful study that they've done to date on this.
Team, welcome back to a menage a trois of Mops and Mo's action this week. We have uh, regular guest Alex Morrow on the pod. Alex, welcome.
I come on occasionally. Yeah.
Occasionally. And frequent caller, John, how are you?
Good. Glad to be here. Thanks for having me again.
Yeah, happy to have you. We'll get into some admin stuff here in a second, but just as an overview, purpose of today, we've accumulated or accrued, I should say, a number of frequently asked questions pertaining to injury prevention, rehabilitation, all that type of stuff. We're going to throw them at John. He's going to throw answers back. And yeah, did I miss anything?
I mean, I think we need to make it clear for the audience that John is not just like a repeat guest on the pod. He's part of the team.
Yeah, well, yeah, and so are you, but it's a bit.
Yeah, it's a bit, but like for me, they get it. I'm on every single episode, sure. But John is like part of the team. He has created content for us.
Yes.
People listen to the podcast and don't spend a lot of time on the website. If they work their way over to the blog, they will find some content from John there.
Mm-hmm.
And if they
Actually,
work
a
their way,
plug for Strava.
Oh, yeah, that is true.
good chance, good opportunity for that.
Hey,
you want to go for it?
There you go. Plug it. Do your thing.
See how many we got right now. Well, I only have one post, but yeah.
So John, while he's figuring out how to use his phone, John created a Strava group for Mops and Mo's. We published this to the Long and Strong team. So you don't have to be doing Long and Strong to join the Mops and Mo's Strava, though I don't know if the link exists anywhere else, does it?
I don't think we've publicized it beyond the people who are on the program yet.
We didn't. We probably should. But the point there for folks that are unfamiliar with Strava, it's an endurance facing app, cycling, running, biking, swimming, basically anything having to do with endurance. And it's a way of being part of a community, tracking your work, sharing your stuff. It's pretty cool. So John's running that. You're contributing how frequently in terms of tips and tricks?
Yeah, right now not that often, but the goal would be at least once a week.
Oh, there you
Will
go.
be Yeah, and it won't just be about running. Like it is multi-sport. It also won't just be about Zone 2, even though it's called the Zone 2 Club. Really, the goal is to kind of share some of the research that I'm reading, and then also trying to make it apply to what people may want to read about, or making it more digestible. And then also potentially in the future, making like group events that they can do virtually or collaboratively, like big races and stuff that people can go to and try and hype those up.
Oh yeah.
And to be clear, when he talks about contributing tips and tricks and sharing the research he's reading, since we're not going to have an intro on this episode, I think it's worth reiterating that John is our injury prevention and rehab subject matter expert for the Mops and Mo's crew here. He's the only one who's actually qualified in that space. People ask us questions about that all the time. So we figured it was about time we brought a physical therapist on board.
He is a official certified chiropractor. So
Oh boy.
that's not true. He's a physical
Yeah, no.
therapist.
I went to a class once for chiropractic care.
Yeah. Speaking of Zone 2, merch plug?
Yeah, we can do a merch plug. It'll definitely be more publicized by the time this comes out.
sure.
Where we stand at the exact moment of recording is I'm awaiting confirmation that stickers are stocked in inventory at the distributor so that I can go full send on letting everybody know about the merch stuff. By the
Mhm.
time you hear this episode, it'll probably be like 2.5 weeks from now. So all that stuff should be out there live. Everybody should know about it. But yeah, any minute now. And by now, I mean over 2 weeks before you hear this,
Mhm.
we should be pushing all the merch stuff. The store technically exists already. People who are like real fans and are checking our website every day might have seen the shop link on there.
I think we call it a soft launch. We soft launched.
Yeah, we soft launched it. It's
Soft
soft
launch.
exist.
Yeah, yeah. So for folks who run slowly but want everyone to know that this is their Zone 2 pace, We do have a shirt that has that printed on the back. We wanted to make that specifically for the people so that nobody out there thinks that you're slow. You're not slow. You're just training intentionally.
Or if you are slow, just wear it and they'll think
Exactly.
you're fast. Yeah.
Perfect. Okay, let's get started. So we have a lot of these. I don't know if we'll get through all of them. We'll shoot to get through all of them. See what happens. We'll just go top to bottom. Alex, you want to kick it off?
Sure. And I've seen this one kind of come up on the internet a little bit. It's tangentially related to weightlifting belts, so I don't know if we want to dig into that one or not. But the broader category here of braces, sleeves, wrist wraps, all that kind of stuff, does it help? And I do want to be weird about this and say the perception I got as somebody who went through a knee surgery and then handed off to an actual expert here to take it from me. I was initially prescribed a brace after my knee surgery, and there was no real guidance given to me on like when to stop wearing it, what activities to wear it for, what activities to not wear it for. And this is long before I was like officially in the human performance space, didn't have some of the resources I do now. So I was just using the Google machine, watching some YouTube videos, stuff like that, and eventually stumbled on something that seemed to tell me that after that initial serious rehab phase, the brace wasn't really doing anything for me other than like feeding into some kinesiophobia stuff. So I eventually ditched it and never had any issues again. But I don't know like what the real guidance is. So I think that's what kind of people are wondering about is when to use it, when not to. Does it actually help? Is it more of a placebo?
For sure. Um, yeah, I guess we can go a couple different ways. Well, first, I'll start with the braces that actually do have some good research support. So in your situation, you had ACL reconstruction, is that correct?
That's correct.
Okay, cool. There actually is some support for a functional knee brace for people that are post reconstruction that are getting back into contact sports. In addition to that, people with MCL injuries and ligamentous injuries of the knee that are maybe grade 1, grade 2 in nature, but they are still required to perform on a high level. That's why you probably will see some of those bigger football players and O linemen, D linemen wearing those functional knee supports out on the field. That is not only supportive, but also can be prophylactic in preventing future injuries. There are a couple other braces that actually do have some good research support. One of the biggest ones I think that is applicable to military populations is ankle bracing. So post-inversion ankle sprain, there's been several research articles, including a systematic review in 2021 that looked at its effectiveness, both comparing it to taping and then another study comparing it to immobilization, and found that it both helps decrease recovery time and the risk of re-injury. And the other one that has some pretty good support in regards to bracing is carpal tunnel syndrome. There's some support for night splinting, though this one isn't particularly as applicable to our younger population. Um, but the ones you guys probably really care about and the ones that I care about are lifter belts, knee sleeves, and then wrist wraps. So we'll just kind of go through those. There is really no research on injury prevention, but certainly the theory is there. Starting off with lifter belts, there is some research that does say it can increase intra-abdominal pressure and then also can increase trunk stiffness, which theoretically, that's going to make you be able to lift more weight and be able to maintain better mechanics. But really, these studies only looked at being near max percentage of your 1RM. So really using it for submax work is not necessary or beneficial. They did do a study for knee sleeves looking at patellofemoral pain and did find that it can actually help reduce symptoms for those patients. Or if you're squatting heavy with knee sleeves with the intent of being able to continue to squat heavy, I'd say that maybe you need to take a look at what you're doing and try and address the knee pain without the use of those sleeves and get the rehab done. And then lastly, wrist wraps. They did find that actually there was a study done back in 2020. They found some improved wrist stability and then reduced strain as well. So there certainly is some support for the more formalized braces. There's some theoretical support for kind of the gym bro braces and stuff like that. Hopefully that answers that. But if you're looking for like a recommendation on those things, I can give it to you, but I think it's sport dependent.
So As one follow-up, because this came up in some of the questions, is there any need to worry about like loss of developing your own stability because you're using something external to handle it? So I can partly answer one from my perspective. You can correct me if I'm wrong. Some people talk about like if you use a lifting belt, you're not going to develop your own core stability. And that just seems like people are misunderstanding how a lifting belt works. The lifting belt provides you something to press against for developing intra-abdominal pressure. I'm not saying everybody has to have a belt or nobody should use a belt, but I don't think if you're using a belt, you need to worry that your core is not going to get strong. You're still using your core.
You hear that everywhere,
Sure.
though.
You do hear it all the time.
Everybody says that.
Is
Yeah,
there anything like that with other braces where like if you wear them, it might cause problems down the road?
no, I don't think there's much research at all to suggest that you're going to have loss in stability and or proprioception. I think that's misguided theory that was taken and applied. However, what I will say, the problem lies more so in the braces than the lifter belts in immobilization. So if you are solely reliant on the brace and you wear it 24/7 and it's not just a functional thing during sports or during certain military activities, then yeah, potentially you're going to atrophy in those regions and not necessarily be able to keep the strength and stability that you would have otherwise if you didn't use those braces. In regards to lifter belts, really you should only be wearing it during heavy lifts and it provides good support. And there's like guys love it. I mean, it's super. Like, if it's legal in the USAPL, then why shouldn't it be legal for you to do your one RM or your one rep max when you're in the gym as well?
Cool. I think that answers that.
All right. Number two, and I'm assuming, well, so the question is how to decide whether or not to get surgery. And I'm assuming we can set aside like your arm just fell off. I think this is more, maybe chronic slash acute pain type situation. Should I progress into surgery or not? And I'm going to challenge you and say, you can't say it depends.
Was there any more context given on this question?
Literally, how to decide whether or not to get a surgery?
So
Question
the
mark.
question plugged into the box was pretty simplified, but I think having had conversations like this with people, I think it comes from a place of like surgeons always want to cut on people. So how do I know whether to take the surgeon's recommendation or whether to get surgery? But at the same time, like, is physical therapy actually going to work? I don't know. I do know I was just listening to a barbell medicine episode from like 3 or 4 weeks ago where they mentioned some study where like 75% of patients who participated in this particular prehab program ended up declining surgery because they saw enough benefit from the prehab program that they ultimately decided they didn't need the surgery. However, and this is a little bit unlike the barbell medicine guys, they had citations for a lot of things. They did not have a citation in the show notes for that claim. So I couldn't find the study they were referring to.
Yeah, that's. I wonder if that was done internally, and that was
Hmm.
just kind of what they found. You do see that a lot. Still a good news story though.
Yeah.
I think that highlights kind of the at least the vignette you're bringing up, Alex, of should I do physical therapy? Should I do surgery? Unless it's like clearly indicated and you had a traumatic type injury that requires surgery within 48 to 72 hours or 2 to 3 weeks. And these are things like tendon ligament tears
Yeah.
that
Pec
like
tear.
a patella, like, yeah, like we've had a few distal bicep tears recently. You got to get surgery within 2 to 3 weeks. Otherwise you run the risk of that bicep tendon retracting up too high and it becomes non-surgical. But for the majority of the people that are probably asking these questions, what does the care look like so far? Are you only seeing your primary care? They give you meds, they tell you to ice, they tell you to rest. If that's what you've done for 3 months and then you're no better, well, you really haven't given it the formalized try that you need to. If you have done the full formalized physical therapy and your physical therapist is good, doing good standard of care, generally people are going to get better and don't require surgery. However, there are certainly instances where, depending upon what the patient has to do for their job, surgery may be more indicated, even if physical therapy can't get them back to where they need to be. They may be able to help them with certain impairments, but there may still be something significantly limiting them for their job that they can't do. I think the other thing that you need to take into account is the thing about surgery that a lot of people may not necessarily fess up to is there is a pretty big like yellow flags or behavioral health kind of role in this. Um, for example, you get an MRI your back, you find out you have a disc herniation, and you think, there goes your career right there. I'm going to have to live with this the rest of my life. I'm going to have surgery. There's no way this thing is going to get any better. When in reality, most disc herniations heal, one, spontaneously without you doing anything. And then two, you can make a significant amount of progress with physical therapy and still have a disc herniation. You're really only left to be about the 5% of people that still require surgery, and nothing that you do is going to help it except for that surgery. So hopefully that answers that question. I try to have a long conversation with my patients in regards to whether or not they need to go in for surgery. But generally, if the job demands are too high for what they can do conservatively, then we push them to surgery.
So I want to reiterate one thing and then ask a follow-on question. First, I want to reiterate the point you made about disc herniations, because I've had this conversation with people like in the DMs on the Instagram page of people who were told they had a disc herniation and were never told that it could heal. Like they walked out of that office, and like whether or not the provider said it or not, who knows? Because there's interesting research on how much people retain and remember correctly from conversations with providers. But like letting patients walk out the door not knowing that it's a condition that will almost, not almost, but very, very likely heal. And you mentioned the numbers. We're talking like 80-90% plus of disc herniations will heal on their own, whether we do anything or not. It's just the natural history of the condition. I think people need to hear that, because I hear all too often people just kind of gave up on certain activities because they were told they had this injury and were never told it could heal.
I don't think
My
it's 80 to
fault.
90% just heal on their own. I will
Yeah.
say that. I think it's probably closer to 50% of
Okay.
people will just have it heal on their own. I think the bigger thing is that whether or not the picture heals, which a majority of
Hmm.
disc herniations
Sure.
do, symptoms often go away much quicker than the herniation does.
Fair enough. My follow-on question then is, when I tore my ACL, the way it was explained to me and like all these videos I saw online showed like for a complete tear, the two ends like pulling away from each other. And everybody's saying like you have to have a surgery for this to heal. Then there's some like cool futuristic stuff where they like pull the ends into like a lattice work thing full of stem cells, and they're talking about how they can do that method. But what seems to be coming out recently is that ACLs can heal on their own in many more cases than people suggested was the case even just a few years ago. I'm curious if you know anything about that. And then I'm also curious if like it was accepted as just a fact that when like the ends pull away from each other, so no healing without surgical intervention is possible. How much more is there for us to like learn? Because that seems like something that kind of foundational, and like maybe there's that much more for us to learn about some of these injury processes.
Yeah, the group you're referring to, they're called copers. So they call them in the research, and it's a good proportion of people that can deal with,
Copers. Oh,
yeah,
Coper. Yeah. Okay.
copers
Yeah.
and non-copers. It's people that can deal with an ACL tear and never need surgery. There's a certain population, generally they're a little bit older. They may not necessarily be participating in uh, sports like the younger population does. But yeah, there's definitely a good amount of research for copers. I will say this for the ACL, it's probably a rarity if it does, but those two ends of the ACL, when it tears, they can approximate, which doesn't allow it to heal as would other ligaments of the body, things like the PCL, where that can approximate and then can also heal on its own. Those are generally treated non-surgically. So the reason they're called copers is because they do not have a functioning ligament where it once was. So what they can do instead is they improve their dynamic stability of the muscles around the knee so well that it doesn't necessarily like essentially they've created a fortress around the knee to prevent it from further injury. But the reason that you have it for that certain population is because you may not necessarily be, predisposing them to pivoting, to quick jumping movements, cutting movements, things that might cause a similar mechanism that originally injured the ACL in the first place.
So I do want to clarify what I said. I'm certainly aware of copers. There have been high level athletes with non-functional ACLs that have done really cool things. What I'm referring to is more recent research, and I'm talking like 2023 that I see. I'm Googling citations here. I see 2022, I see 2023 of like legitimate spontaneous ACL healing. No surgical intervention, like return to a functional ACL.
That you said it was like they did repeat MRIs and found
Yes.
healing.
It
Yeah.
just fixed itself.
I was under the impression that was like impossible,
I wouldn't say it, definitely not impossible. Nothing's
Anything is
impossible.
but
possible.
like now I'm seeing, and I don't know how reliable sports med res is or whatever, but they're talking about like in up to potentially 30% of cases, spontaneous healing is possible, but we still don't really know what the predictors are of whether that happens. Lots of other stuff I don't understand that's more for rehab professionals like yourself. I don't know.
No, that's cool. I have to look into it. I mean, I definitely believe it that it can happen spontaneously. It just doesn't happen often.
Yeah.
How many people were in the study?
I would have to, all I'm looking at is like headlines at this point. There's like news headlines and then like 3 or 4 studies. I can send you the links after we get this. Maybe there's a follow-up episode here. Who knows?
Yeah, I'd have to do some more research into that. Um, yeah, that'd be super cool. That'd be awesome.
I'll
It's just
drop them in the
it's
chat or whatever, but there's a 2022 paper in BMJ Open Sport and Exercise Medicine, Phil Bay. There's an osteoarthritis and cartilage paper, same author. That might even be the same paper republished. 2023 new article, same author again. 2023 different author. So there's like a handful of studies here of pretty small groups in the studies, but like evidence of certainly a non-zero rate of spontaneous healing, even after a complete rupture.
that's cool. That's awesome.
Yeah.
Yeah, I'd be interested to see what like the athletic population is.
Yeah.
Um,
I'll drop some links.
that would be super cool in the future to be able to progress to that. I mean, ACL reconstruction, you'll be out for at least 9 months, typically 12.
Yeah.
That's a long time to be away from doing things that you love.
Wasn't Derrick Henry out for like 45 minutes?
Adrian Peterson.
Adrian Peterson. That's who it was.
I've said this before on the podcast, but watching the Adrian Peterson highlight MVP reel video was the most important part of my rehab process. It's crucial.
All right, moving on. Pain. When to push through it, when to avoid it.
I'm trying to figure out how I want to answer this question. Well, I'll start with this.
Accurately,
some
preferably.
first of all, some pain is useful in regards to nociception, which is essentially the body sensation of pain. That's acutely, usually typically right after you do something that causes injury within the first 24 to 72 hours. Typically, what we call it is chemical pain. That's good pain. That's allowing for essentially that inflammatory response to do its work. What I think the better, or I guess probably what they're asking when they're asking this question is recurrent chronic pain, subacute pain, and then also injuries that may not necessarily have been traumatic in nature, but you just kind of wake up with it. What does that look like? I don't know if you guys are going to touch on this, but I think that I came across this when I was prepping for it. And I really like it. Have you guys kind of heard that the guy who promoted rice back in the day he retracted his statement?
Oh yeah.
Yeah, I mean that was back in 2015 when he did it. We came across this new thing. It's called Peace and Love. It was Blaise Dubois put it forth in 2019 in an editorial in the British Journal of Sports Med. I think it's pretty interesting. He does have some support. I haven't read too much on it, but I think this kind of helps answer that pain question. So I would say generally, first of all, full avoidance of pain is generally not indicated. So if you kind of follow what he says, this kind of helps answer this question. So peace and love, it's a mnemonic. Peace is typically what you do right after injury. Protection, those first 3 days, you're not going to be continually going into pain to exacerbate that inflammatory response. Things like, oh, I broke my ankle doing fast roping, right? You're probably not going to be putting a lot of weight through that ankle to allow the body to do its initial healing and kind of let the pain settle down. Or I just strained my hamstring, tore my hamstring doing sprints. You're probably not going to be putting too much weight. You're definitely not going to be doing too many hamstring based exercises early on. Elevation, that's help reduce swelling. And then avoid anti-inflammatories as they may inhibit repair. I think that's more theory right now.
Wait, he wrapped all
From
that up into A?
of is avoid.
Okay.
E is elevation.
Right.
A, avoid anti-inflammatories, including ice and NSAIDs, as they may inhibit repair. I don't think there's as great of support for this. I think it's more theoretical. However, sometimes can be way too high that you are required to use either anti-inflammatories or even ice. Compression is for C, minimize swelling. And then lastly, education to promote active recovery. The other ones happen once kind of that chemical pain has gone down. Loading, be optimistic. Vascularization, such as pain-free aerobic exercise, and then specific exercise for rehab work. So I don't know if I can put that. I might put that out in an article or something like that later on. But I think that's pretty valuable.
Do we know why he thought ice was the move and then changed it?
I think the theory was it would minimize the amount of bad metabolites and things and there's what they call substance P, which is a pain signal that goes to the area and helps propagate pain signals. It would minimize that and thereby allow for recovery. But what he said in his retractions is there's been numerous studies that both show that icing doesn't actually help in recovery, and then also it may inhibit recovery as well. I believe that's what it is. I'd have to look at his original article though, but it's pretty wild though. Guy puts it forward and then it just becomes gospel to most rehab professionals for 40 years, 50 years.
Still is.
Yeah.
So I'm curious, two follow-up questions there. First one, are there it seems like there are probably still some situations where ice or anti-inflammatories may be called for, where reducing inflammation is a priority, potentially either to like prepare for some kind of surgical intervention because less inflammation makes it easier for the surgeon, or maybe to like work in a range of motion that you can't work in without reducing the inflammation. Is that the case, or am I just talking out my ass?
I can't really speak to the surgeon thing. I haven't really heard that one. Generally, regardless of the inflammation, the surgeon is going to be able to do what he needs to do.
That's fair. I was just told that, like, leading into my ACL surgery, I was told repeatedly that like a huge part of the reason to like delay the surgery and do all the prehab was that reduced inflammation meant better surgical outcomes. I don't know.
That's probably more for like the ACL specifically. They talk about doing surgery immediately after the injury, where yeah, you do have a lot of swelling in the area, but also not doing it too late before fibrosis can occur. I think it is injury specific though. In regards to like range of motion, icing generally does not help with the range of motion. The only time that I will typically ever use icing in the clinic is when pain is just so way too high and the guy has to get back to his job that day. Like I'll set him up on the compression with the ice, like the kind of like the game ready. So we have something called the Med 4 Elite, which is just a fancy game ready.
Love
and
that
set
guy.
him up on that guy. And it's a total feel good thing. You do take advantage of the compression, the elevation, but you also get some ice, which is a little nice for the patient. They generally like that.
And then my other one is, how do you, as a provider, deal with the serious degree of subjectivity involved in pain assessment? I mean, like we just at work, I think it was like a couple of days ago, we had somebody come in and the PT asked, like, what's your pain at right now? And I think they said like a 9. And they were like walking in totally fine, having a totally normal conversation. Like, but by the pain scale, as I understand it, 9, like talking would be difficult. Movement would be essentially out of the question. Like, people clearly have very different ideas of what a 9 or a 2 or a 5 on the pain scale mean. How does the practitioner navigate that subjectivity?
Ooh, that's I think that's part of the art of physical therapy. Generally, what I've learned though is you got to start with like taking the patient at face value. Like just because it's 6 out of 10 for them, and it might be a 2 out of 10 for you, or even a 1 out of 10 for the 80-year-old lady who's been dealing with pain for a long time. You have to take it for that at their face value at first, and then generally what happens through follow-up evals and treatments, you'll be able to learn a little bit more as to what that initial pain level means. So say they're coming out, in their initial eval, 7 out of 10, but they're talking to you, they're happy, right? You're pressing on the painful spot and they're not really jumping off the table or anything like that. It's obviously not a 7 out of 10. However, what does that look like as they start doing treatments? Does it stay that 7 out of 10? Does it get to a 6, a 5? A lot of those people that come in with this certain amount of pain, sooner rather than later, they'll be in 0 out of 10 pain. I think a lot of people don't understand that pain is a very normal part of life. And it does serve a purpose a lot of the times as well. Unfortunately, a lot of people that we see just don't understand that pain is normal and want to be completely pain-free. And I don't think that they're able to do anything until they are pain-free. But that's just not reasonable, especially with the work that soldiers do. Just the job requirements are too high for them to be able to live a completely pain-free life. So I think to answer your question, in dealing with pain, it's one, take them at their face value. Two, learn a little bit about them, and then three, be able to have the conversation as to what's also contributing to that pain. It's rarely ever just physical. There could be other stuff going on in their lives as well, and being able to speak to that and refer them to the right professional as needed.
Okay. I think that brings us to a question that might be potentially controversial. We'll see if we get agreement across the participants on here. The question was about, does running cadence affect injury risk? And I'll throw that
This is
to
a hot
John to
topic
answer
for
first.
Alex right now.
This is a great topic. I don't remember exactly what you were putting out on Instagram. I don't know if you remind me. Were you saying
We
that
were fighting about 180.
there was no evidence to support 180?
Yeah, so I'll do like a mini version of a long discussion I have all the time.
Yeah.
But 180 is indeed roughly the average that we see when we look at marathon and ultra marathon runners at an elite level.
It's steps per minute, by the way, people.
Yes, a 180 cadence.
Yes.
The issue is average doesn't mean optimal. Average just means average. And it's average for a certain subset of people running at a certain distance at certain speeds. And when we look at when we break down the populations that were studied in there, they're all over the board. Cadence is as low as 150 and as high as 200. Men tend to have slightly lower cadences than women. Tall people tend to have slightly lower cadences than shorter people. And regardless of your height and regardless of your gender, the faster you run, the faster your cadence tends to be. And so I do take issue with trying to tell everybody that 180 is somehow magical. I'm totally fine with telling people that in many, many cases, increasing cadence is a good cue, and certainly focusing on increasing cadence rather than increasing stride length, because that would be a mistake and leads to overstriding and more braking forces and things like that. I don't love telling people, like, you can go on Spotify and find 180 BPM playlists so that you can like listen to songs and run at exactly that cadence. And I don't love that idea. It seems like we're over engineering running stride stuff at that point based on just an average number from a certain population.
Some of those playlists are sick, though, I will say.
Yeah, they are pretty good. 180 beats per minute is
That's a banging beat.
it's a good cadence to run to. Yeah, I mean, I would agree with all that. There's no arguing going on here. There definitely is not a dearth of evidence. There's just a dearth of high quality evidence supporting the 180 beats per minute. There was a study that was done in 2020 where they looked at 381 soldiers, and they actually did not find a relationship between step rate and injury risk. This is the largest population, to my knowledge. I'm sure there's probably bigger ones going on now that kind of looks at that, specifically at Army soldiers. But I think that's probably the most like powerful study that they've done to date on this. Some of the more weaker studies that were performed were not on soldiers. They looked more at high school cross country runners and then recreational runners. It looked at higher cadences, and yeah, they found a theoretical improvement. But the problem is that generalizable to all populations. I would also agree with you that like maybe there's potentially more evidence for increasing your cadence by only 5 to 10%. Say you're dealing with shin splints or low back pain, and maybe your stride is too big. Generally, I wouldn't just blanket recommendation. I wouldn't give this as a blanket recommendation. It's typically from one-on-one assessment. But the thing that I think is just funny is that this is such an emotional topic for people, but it is free. Just like
Mhm.
prescribing a cadence is free. You can get, if you have a Spotify membership, 180 beats per minute. Easy. There's your cadence. Or if you don't have music on your phone, you can easily download Metro Timer and set it, the metronome, to 180 beats per minute, which is insane. You'd be kind of
Such a serial killer move.
psychopathic to do something like that. But in a
I,
world where
I
everybody's trying to sell you
think
their products, I definitely prefer the free ones.
I just get real frustrated because I have been involved in scenarios where I was directed to, as part of a running class, play that metronome and make 30 or 40 people of different heights, different running abilities, all practice running to the metronome.
those boys
And
love that.
there's not a lot that tells me that that helped. And like tiny asterisk, I'm going to throw in the show notes an article I really like on the topic by Alex Hutchinson. It's one I go back to a lot because he makes the argument in like a pretty clear way. Not necessarily an exercise scientist, but he is a PhD physicist who worked in like the NSA's quantum computing group as well as competing at the international level in running. So the guy's pretty smart and pretty
And
fast.
he wrote Endure, which is one of the best sports
Yeah.
science books out there.
Yeah.
Um, Also, just to throw some light on some other playlist, I typed in on Spotify. I've got a 150 beats per minute mix, 160, 150 to 160. So that one, I guess, goes everywhere. 170, 155, 140. I think you can get a BPM. Here's one, 170 to 171 beats per minute running sweet spot mix. So you can go anywhere with these.
The running subreddit says that like 145 or 150 is a great cadence for zone two. So maybe you play with which playlist you listen to based on the intensity of your run.
Maybe just run. Maybe
Running
just
the
Yeah,
running subreddit is not an
yeah.
evidence-based place to go. I'm not actually endorsing a cadence for
asterisk.
zone two.
Yeah, man. Yeah, I'm more just like just go run. Stop thinking about it.
Yeah, I'm not really a music zone two guy either. Zone two is good for podcasts,
Hmm.
audiobooks.
Hmm.
Yeah, that's about it.
There's a large body of research at this point showing that people who listen to the Mops and Mo's podcast while they do zone two runs achieve
True.
greater results than literally
It's
anyone.
anecdotal, which is the best kind of research. I
Yeah.
mean,
No, I
I
hear
mean,
it.
it's
That's
real.
that's that's platinum level right there.
Hmm. Okay, let's carry on. Alex, you want to take this one?
Sure. Stress fractures, hot topic in the military. I've even seen stuff suggesting that like femoral neck stress injuries are like a bellwether injury in the effectiveness of armies going back decades. Like it's an indicator of their training status and their susceptibility to injury and all this kind of stuff. Um, but just in general, for stress fractures as a broad topic, not a particular stress fracture, what are the risk factors we're looking at? What are some prevention steps we can take and how to manage it if you're somebody who's dealing with one?
I'm just going to stick with the modifiable risk factors. The non-modifiable ones
Sure.
are rather contentious, and well, you can't adjust them obviously.
Yeah.
Low bone mineral density, lower body weight, lower BMI, which is actually pretty interesting. Poor physical fitness, and then poor history of training. Those are some of the big modifiable risk factors right there. We can talk about each one if we want, but and I don't know if there's been any like long-term studies to compare like bone mineral density of soldiers in the 80s versus soldiers in the 2020s. However, the stress fractures are super common in the military. I think the stat is 5.69 uh, per 1,000 person years. So there's 5.69 cases for every 1,000 people observed over 1 year, which is a super high number of injuries when in the civilian population, it's like 1 to 7% in like runners. And we talk about, I mean, I went to a course this weekend and a guy made a joke about stress fractures is it just never happens in their population, but it's so common to see stress fractures in military populations, specifically the recruits. Did you ask what do you do for treatment as well? Just remind me.
Yeah, management, prevention and management were both subcategories.
Yeah. I will say this, if you're a recruit and didn't do enough prior to joining the military, it's probably a little too late. Your prevention strategy at that point is you're going to likely be at some part of like weight bearing restrictions for 6 to 8 weeks, and then good luck. You start whatever phase of basic training you're supposed to be on. For people that are actually in the military that have made it past basic training and OSIT, and stress fractures that happen there, they're generally due to poor training, but also could be due to poor diet, lifestyle factors, things like that. So if you're not taking care of, good vitamin D, good calcium intake, that's one thing, and also progressively training your fitness and not just kind of bouncing around from 0 miles 1 week to 25 miles the next week to 5 miles the week after that. These are general strategies that you can do to prevent you from having stress fractures. Unfortunately, the treatment, there's really nothing special that we do. Really, it's for certain grades of stress fractures, the higher grades, grades 3s and grade 4s. Grade 3s are some of the main ones we see. Those are the ones with an actual fracture line. And these are the ones, depending upon the area of the fracture, will either make them non-weight bearing for 6 to 8 weeks or partial weight bearing, or even full weight bearing if it's a lower risk bone that's fractured. For grade 4s, they sometimes require a pin in it, fixation, to allow them for full healing. Otherwise, the bone runs the risk of becoming necrotic.
I will shout out one thing. You mentioned studies on the topic. This is like an open call. I know Usarium has been doing the Army study, ARMI. It stands for Arium Reduction in Musculoskeletal Injury, so Army Research Institute in Environmental Medicine Reduction in Musculoskeletal Injury. There's a study protocol published out there from a few years ago. I know they've like given updates internal to the Army, but if anybody listening to this knows anybody involved in that, I know we have a few Usarian people who listen to the podcast. If anybody from that would be willing to like come give a public update on the Army study results in terms of bone density stuff, I've heard there's been some like promising and exciting indications in terms of the potential gains in bone mineral density during basic training with proper nutrition and load management and things like that. I think this involved like femoral bone density scans at like multiple points through basic training, blood sampling, a few other things. I'm really curious about how that study's going. If anybody out there can give us some insight.
That's pretty cool.
Yeah. It's getting to the point where like if we don't get a handle on this, like a MEPS bone density scan will be required to mitigate the ridiculous injury rates we're seeing in initial entry training.
Yeah, I mean the feasibility of putting everyone through a DEXA is insane. There's no way that would happen. Even blood work and all that stuff and continual blood work, that seems like a big ask.
Yeah.
Can you imagine a bone mineral density scan requirement?
DEXA takes like 15 minutes to do.
I mean, the cost savings might equal out, but that's, yeah.
I don't know. An economist will figure that one out for us.
Treatment for Shin splints. What's recommended? Another common one, I think.
Yeah, super common. I think up to like 35% in Army recruits, people deal with shin splints.
Do they actually have them, or do they just assume that they have them?
I'm not sure where they got that. It could have been from the medical surveillance reports where they're diagnosed with shin splints in Genesis or Alta, whenever the study was done, and that's what they take from there. However, let's see, treatment. So first of all, like being able to diagnose exactly what the problem is. One, if it is a bone stress injury, then you are going to treat it a little bit differently. We kind of talked about some of the strategies of non-weight bearing. We didn't really go through a walk to jog progression. If it is strictly bone, a good walk to jog progression is probably all you need, and then you treat impairments, weaknesses, mobility deficits as needed. For shin splints, though, it typically happen in two different regions. One is on the medial portion of the bone, where that tibialis posterior attaches into what's called the periosteum. Periosteum is essentially a connective tissue that coats the bone. It houses a lot of vessels and nerve endings in there, which can be a ripe place for pain. The other spot is the tibialis anterior, which is more on the front side of your shin bone. And that often occurs with the eccentric lowering or the loading response during running and or walking or rucking. Um, and then being able to identify like the specific location, that's going to kind of change up your treatment strategies. And we can first start off with exercise. And some of the exercises I think are super beneficial for, I'll just throw it kind of all together. Generally, these muscles are not particularly trained super well. So being able to do some targeted like tissue work is beneficial. Things like calf raises with you take a lacrosse ball, you put that between your heels. You're going to have a little bit of inversion. You can do standing heel raises, heel walks. If you have the ability to do this, the tib raise machine, or not machine, but the little plastic thing that you attach weights onto it, those are super cool because the tib anterior is rarely trained that way. You can also incorporate balance and eventually progress to single leg plyometrics, jumping. All that is super beneficial for ankle stability. Some of the cool things, though, that we play around with treatment-wise, I don't know if you guys want to talk about this, but dry needling, super powerful tool. They do what's actually called periosteal pecking. You take the needle, you send it through the painful spot, and you ride it all the way down to the bone. And then on the bone, you tap literally onto that periosteum for about 10 to 15 seconds. There actually have been studies that have looked at periosteal pecking and found positive results. Not only does the theory is that it improves healing, but also improves circulation.
Why
So if
did
you
they
do have
name it
visible,
that?
well, it is the periosteum, and
I
I
know.
think for alliteration, because it sounds cool, periosteal pecking. That's probably what it
It
is. I don't
sounds
know
like a
I
though.
lot of
think
things that aren't what it is, but you know.
separate from that, listeners need to know the faces Drew was making the whole time John was talking
Only
there.
because I've known John for a long time and we've said some things. And I can't
It does
imagine
sound
being
like
on his table, be like, I'm gonna peck your periosteum real quick. I'd be like, I'm out of here.
usually, yeah, usually it's a surprise. I don't warn them beforehand.
No.
But it's good for your bone health. That's great. I'm really happy to hear that.
Yeah, there is some research for it. So, and we play around with it. And if
It's
if
not
you
it's
got
not
if
just
you
him torturing soldiers for fun.
it doesn't always hurt. I will say that 50-50. Sometimes it's awful. Sometimes it is terrible.
I hate dry needling.
But the other thing with dry needling is it is beneficial to go into a little bit of pain. If you're not going into a little bit of pain, then you're not going to have the inhibitory response from the spinal cord on those pain mechanisms.
We ought to
So
do a dry needling episode.
It's probably called for.
I mean, yeah, because it's like the people love that shit.
I need both sides of the debate represented.
We could do that live. That'd be
It'd be
kind
a
of
kind of fun
fun.
one.
that would be a fun one.
Are you pro or oh, you're obviously pro. You peck people.
Periosteal peck, yeah.
Yeah, you're a big
People.
pecker. Um, this could spiral very quickly. Are we done on
Should we
the
move on? Is that enough of an
shin
answer to
splints?
the shin splints one? All right.
Yeah, that's fine.
I'm shuffling around a little bit because I think the next few here flow together with kind of the shin splints thing of just like common conditions, some occasional misunderstandings within those conditions, things like that. Plantar fasciitis. It's a term I've heard used a lot, but more recently I hear that the vocabulary police are changing it to plantar fasciosis and or just calling it heel pain. My superficial understanding of why is because it's degenerative rather than inflammatory, so we have to switch from itis to osis. But I don't actually know what that means. Like I can say those words and sound smart, so I would love
You
your
sound smart.
perspective
You do.
on like what's going on here, what is this condition, what can we do to help people with it?
Yeah, I mean, you did touch on it. Itis whether, tendonitis, fasciitis, that is an inflammatory condition. And it's typically the inflammation within the first 72 hours. Osis is more chronic in nature. And yes, technically the definition does incorporate a degenerative nature, though I would never say that to a patient. Degeneration generally is not taken well by
Sure.
patients, and then they're going to remember that the rest of their lives and then no longer be able to use said body part because this guy said I had degeneration. So
Yeah, it's like saying bone on bone, or yeah.
exactly. Yeah, exactly. So if you want to get into semantics, sure. Somebody dealing with plantar fascial pain for 3 months would have plantar fasciosis or plantar fasciopathy at that point. But in regards to the treatment, it doesn't really matter what you call it. I think first things first, like figuring out like if it truly is like plantar fascial pain is important. There's definitely a lot of cases of what was like diagnosed as plantar fasciitis that could be referred pain from the low back. I mean, you do have nerve roots that go right down to the bottom of the foot and insert onto a bunch of the foot muscles down there that are areas of pain. Um, Typically, plantar fascia pain is one-sided. It's worse in the morning with the first few steps, but then the more you walk, you generally feel a little bit better. Um, and a way to really kind of rule it in is look up from the foot. Are you having referred pain from any of the more proximal joints? If you are, then you probably need to, get a second opinion. The other thing too, it can be bilateral. I think maybe up to 30% of cases can be bilateral, but again, not as common. It's actually pretty uncommon to have it bilateral, and if it is, a lot of times that can also be referred for the back.
Okay, cool. Anything else on plantar heel pain
I got
before we
my
move on?
foot dry needled for plantar fasciitis, and that was
Oh, that's
miserable.
that's brutal. Yeah, but powerful. It's good.
It didn't
To do
help.
it
It
right.
just sucked.
You probably didn't do it right.
Maybe they should have
I'm not even
packed.
lying. There's
They
like
should have
there
packed
is
it.
they probably should have packed it. Yeah, they missed the pecking on the medial cut
Hmm.
penial tubercle.
Mm.
Tisk tisk.
How dare they?
Yeah. Now you I mean, I also know you, so maybe you had foot pain, but you also have what, long-term back pain as well?
I'm falling apart, man.
Yeah.
It's what happens.
I think he's saying
Um,
it's all in your head. That's what he's
he's
saying.
told me that. He's told me that for a really long time. And it's probably right. But when you
Yeah.
have a shit PT like John working on you, you don't have a
Yep.
choice.
Exactly.
All right.
You have two words next. Shoulder impingement is what's the
Yeah.
context?
So I think that was the extent of the message. It was just like my question is shoulder impingement. But I've also seen like a lot of discussion of like whether it's real, like what is it, what causes it, do certain exercises impinge the shoulder more? Like people are always hating on like upright rows or whatever for shoulder impingement
I
reasons.
think CrossFit popularized that one.
I feel like there's more here than people give it credit for in superficial discussion. So I just want to hear your take on shoulder impingement in general.
That's funny you say that. I remember when I was like 12 working out at the YMCA, I was doing shoulder shrugs, and one of my buddy's dads was like, when you do your shrugs, you can only shrug upward. You can't rotate your shoulders backward.
Mm.
But when I rotated my shoulders backward, I actually felt it in my traps. I mean, I was also 12 at the time, so I didn't really know. But like things like that have been like perpetuated, which is just not true. Same thing with upright rows, pulling movements, all that jazz. I mean, the people that are saying that also do snatches and clean and jerks and things that are going to
Which
be
involve an upright row in the movement. Yeah.
exactly involved in upright row. Shoulder impingement is real. It is very common, and there are several different types. One of the ones that like probably the main one that people run into is external impingement or subacromial impingement, which is when the head of the humerus abuts onto the supraspinatus within the essentially the subacromial arch. All that being said, that's a lot of jargon right there. Basically, the shoulder pinches a muscle in the front. Internal impingement is more common in overhead movements and throwers, where rotator cuff is repeatedly compressed, but more so in the back. And that's from overhead movements, abduction with external rotation causing those things. We treat it pretty similarly though, if that's what they're looking for. Generally, it is a combined approach of doing some mobility with stability and strength, and then potentially even incorporating some manipulative therapy, and of course, dry needling as well. With mobility, we're not only looking at the shoulders. A lot of the times, especially in the younger population, people are talking about like, my shoulder mobility isn't good, it's not great. It's probably more so a stability issue. So if you're able to have full range of motion, which is I see that a lot, um, the reason that the shoulder blade or the shoulder bone is abutting onto the arm bone or vice versa is because the muscles around the area can't necessarily stabilize well, specifically in more powerful movements and heavier lifting. So we play a pretty big importance on stability. You've got two small external rotators, your infraspinatus and teres minor, and those guys have to counteract the much bigger internal rotators, not just the subscap, which is another rotator cuff muscle, but also the lats, the deltoids, and the pec major. I mean, those are massively powerful muscles that they have the advantage in being able to pull the shoulders forward and potentially putting you at a mechanical disadvantage for certain lifts. So being able to train those, especially like before you're going and doing a heavy lift or you're doing Olympic weightlifting, is super important kind of as a muscle priming. The other thing that we'll do more so specifically for mobility is we'll look at the spine. A lot of times cervical range of motion, thoracic extension, and sometimes even the lats too. Lats can get pretty tight and prevent shoulder flexion, overhead shoulder flexion. So being able to address that can be super beneficial as well. There's so much to be like, this is something to consider if your PT has the capabilities. There is a good amount of research that actually supports like neck and back cracks, in addition to mobilizations for treating shoulder injuries, even if it's only located in the shoulder. So definitely something to ask about if your PT can do that. It's kind of like a, I don't know, wave tops view
There
of
you go.
shoulder impingement. Yeah, I'm learning
Well,
corporate terms.
There you
we
go.
just went over a few different questions. We went over like bottom of your foot pain. We went over shin stuff. We went over shoulder stuff, and it seemed like your answer in every case is dry needling. Is dry needling the answer to all injuries?
I did not say dry needling is the answer. I said it is an option. It is a tool in your toolbox. Let it be
It's for
known.
some
It's not
PTs.
the
That's the
only
only
thing that I do.
John just wants to poke your bones. He's gonna get in there and
peck your bones. But I will say maybe we should save this for the dry needling episode. But like having been around this for a long time, you see a lot of people come in and just like whether it does anything or not, they think it does, and they walk away feeling like they got their, I guess, quote unquote money's worth because it's free in the military. But
to represent the flip side of that conversation a lot though, having worked at an administrative level with all this stuff, dry needling is one of very, very few physical therapy interventions that breaks the skin. And as soon as you break the skin, you have a whole bunch of questions about environment of care, where that treatment is done, sanitation protocols, cleaning protocols, non-porous floors, sink nearby,
nerds.
emergency alert stuff, just a ton of things that the people who run large medical systems get really worked up about. And so the question becomes, how much of what dry needling does is like real? Is the effect size big enough that we care about it? How much of it's placebo? Yada, yada, yada. And
This
if
is
there's that much gray area in it, is it worth all of the elevated environment of care, life safety requirements that come with breaking the skin?
this is why we
First of
need
all,
an
I'll
episode.
tell you the fear of the breaking the skin is so slim to none. Like the risk of, for example, they did a study where they looked at like the transmission of a staph infection. They covered the needle in it, and only 666 microbes actually made it through the skin into the bloodstream. When in reality, it takes like 2.5 million microbes to actually become symptomatic
Wait, they
or
covered a
become
needle.
infected.
They covered a needle in staph and shoved it in somebody.
Mhm.
Did they know they were pecking them with
Yeah, it's
staph
a pretty old
infection?
study. It's a pretty old
Okay.
study.
Love it.
Slightly different
But
ethics of
but
human
I get
subjects
what you're
research at the
saying.
time.
I get what you're saying. I get what you're saying with this. There certainly is like a theoretical fear that you're going to infect someone, and sure, that's a risk. But to date, like most of the studies that look at adverse risk events or risk factor or things that occur after dry needling occurs, it is usually bruising, bleeding, and pain. Those are the main ones, which you tell your patient they may be dealing with that anyways. The other thing too with dry needling that people fail to account for is that acupuncture has been going on for
I was just about to say acupuncture.
so long. And there might be a difference in how we like in the theory of doing it, but at the end of the day, you're sticking needles in people. And there's nothing that is it's a thin monofilament needle that you stick in a muscle. And whether you call that bladder 40 or you call that this trigger point per se, it doesn't matter. It's you're going to be treating the same thing at the end of the day. So a lot of the research fails to incorporate, including some of the broader like physical therapy, like when they write up essentially their statements on certain practices, like they fail to account for all those acupuncture studies because they did not include the word dry needling in the study. So that's a lot of work to be able to go through that, and you probably need to be able to speak either Mandarin or Japanese to be able to get the best understanding of what's going on.
In defense of it, I'm looking at, like, in defense of the people who are worried about it, I am looking at a 2024 study here that did look at a bunch of Chinese literature on acupuncture. Pneumothorax happens enough with like pec dry needling that it is not considered extremely rare. Like we're having a non-zero number of people who end up with punctured lungs as a result of dry needling the pec. Yes, we can decide whether or not to dry needle certain areas based on risk factors that come with it. Dry needling the pecs probably comes with a lot more risk factors than dry needling other muscles, like the soles of your feet or something like that. But you can understand why somebody who doesn't do acupuncture dry needling, but is a medical administrator and worries about these kinds of things, it might be something that like gets them slightly more stressed than like stretching or manual manipulations or telling people to do exercises.
Well, here, speaking of putting a pin in it, let's save that.
Yes.
Let's save that for an acupuncture / dry needling episode.
Deal.
We're gonna stop the FAQ here and then save the rest of these because there are more for
There are a bunch more. Yeah.
for follow-on episode. And instead of taking you guys on a multi-hour journey with us, we'll cut this one, FAQ number 1, and we'll come back. So, Alex, thanks for coming on the podcast. John, thanks for coming on the podcast. Do we have any closing remarks?
I don't. John, you got anything?
No, I think I need to look further into that staff article though.
I'm very curious about who
It's a
decided.
big red flag to me that specifically 666 microbes made it through. That's like
Did I tell
pretty
you how many
specific
are
number.
required for transmission?
A bajillion.
Yeah. No, I got it.
2.5 million.
But like I'm not somebody who's superstitious necessarily, but like that's an oddly
Just a little
specific number of
stitious.
Just a
microbes to
little-
make
a
it
little
through. Just a little
Ah,
stitious.
I hear you. Yeah. Okay. I understand. Yeah.
Oh,
Maybe I'm off. Maybe I'm off of the number.
All right, team. Well, thanks for stopping by this week. Hopefully, you didn't get injured listening to this one. And if you did, head to our website. You can work with John. You can work with any of our injury prevention programs, and we'll see you. We'll see you next time. Hey, Alex. Let's cover our ass real quick.
Oh, great idea, Drew. All right, guys. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent.
Thanks for tuning into this week's episode. Before you go, please rate and review the pod on the listening platform of your choice. You can also visit us on our website at www.mopsinmos.com. That's mops, the letter N, mos.com. You can check out the library of podcast episodes, our latest blog entries, any helpful resources, and also sign up for our newsletter.
Drew nailed it. Just to underline a couple of things, the podcast entries have in-depth show notes on the website. So if you missed anything or you want to read any of the research we talk about, it is all there. You can, at the bottom of the website, sign up with your email and receive future updates from us. The blog posts go a little bit more in depth in kind of written form on a couple of topics we get questions about all the time. But most importantly, I just want to ask all you guys, our best way the word gets out is absolutely word of mouth. So tell your friends, tell the people you work with, anybody you think would find it useful. Thanks for spreading the word.
If you have any questions or comments, feel free to shoot us an email at either Drew or Alex at mopsandmos.com.
Or there's a contact form on the website.
Thank you.